Hey, good morning, everyone, and welcome to UroNurse. We meet here every Saturday at 9 a.m. Central Time. If you're joining us live on YouTube, Facebook, or LinkedIn, welcome to the show. And if you're watching us on YouTube and you haven't just subscribed, what are you waiting for? Hey, if this is your first time watching us on UroNurse, be sure to check out our website at uronurse.com. This is the best place to go to learn more about the show. And if you want to watch our past episodes, all 57 of them, they're there for you to look at. Also, check out the new one, UroNurse Plus area, where you can listen to us in your car on the UroNurse podcast. Just go and sign up at any of your favorite podcasting shows. If you want to get our newsletter, go ahead, subscribe to our newsletter. If you're not getting it, just check out our website. You'll be able to find that there. And if you're watching live and you've got questions, put them in your comment box. No matter how you're watching, the comment box works on everything. So we got a great show this week. We have Marco Carlos, who's going to be speaking about PYLARIFY. So we're going to be talking about that. We're going to break this episode into two sections. The first episode is kind of the branded section. For those of you that are not live, the branded section will be not available on demand because of some restrictions by the company. And then we'll go into our off-label questions and answers, which will be on the show. So a little change from our normal format, but we got to work to work with everything. So let's go ahead and bring our experts in right now and say hi to everybody. Hello, everyone. How you doing?
Good morning.
Hello. Good morning.
All right. So starting off the show, we normally do our introductions and favorite stories and stuff, and we're going to do all that good stuff. I'm going to kick it off with my introduction. For those of you that are new to the show, my name is Vic Sinise. I'm the host and producer of the show. I've been involved in urology for the past 40 years. I also decided, instead of just a favorite story, since we've been here for a while, how about an interesting fact? And I'm going to share an interesting fact about myself. May not know this, but I am a past president of the SUNA organization. 2014 to 2015, I was the boss. So that's an interesting fact about myself. Now, it's an interesting story, and maybe it's more of a question for those out in the audience. You can put it into the comment box. Since we're talking about imaging, do you share your images with the patients? In other words, do you take your patient out and show them their CAT scan, show them their KUB, whatever your particular thing is? In our practice, we do that very commonly. So we take the patients out and show them the pictures. Find it's really interesting for them. So maybe just let us know what you're doing in your particular practices. All right, let's go ahead and swing in Carrie So, who's from the company that's sponsoring the show today. Carrie, go ahead and introduce yourself.
All right. Hi, everybody. I'm Carrie So. And as Vic said, I'm a rep with Lantheus Medical Imaging. That's how I got connected to Marco, and we're here today. I'd say an interesting fact about me is I have known Vic for about 15 years now, I think, because I originally met him when I was a rep with a different company. And it's just, I think it's very funny how time has brought us to this point. I think it's fascinating, but I love seeing what Vic has done and how he's created this whole new platform around education, which I know has just been a big passion of his forever. So I just think it's so crazy that we're here right now doing this, and it's awesome. I love it. I don't know about any interesting facts. So I live in the Chicago area in the suburbs, since I'm in Vic's area as well. I don't know. I've been a rep for many, many years. One crazy fact, because I'm a mother of 4 kids. I'm a rep. I was in the Peace Corps way, way, way back in the day. Wow. And I lived in West Africa. And I think it seems like a whole nother lifetime to me now. And when I tell people, they're kind of like, that don't know me, are like, what? That's insane. So yeah, again, in the distant past now. So yeah.
Yeah. Neat story. Neat fact. All right, John, go ahead and introduce yourself.
Good morning, everyone. I'm a private practice urologist in Gilbert, Arizona, who is paying it forward by sharing my experience in the business and clinical aspects of medicine to help everyone. And to that end, I created something called the Thriving Urology Practice Facebook group. We're currently close to 2,400 US-based urology practice folks collaborate to improve our practices, and it's all for free. An interesting fact, this, Vic, you just sprung this on me, and it's very, very coincidental. Interesting fact is that I do a lot of photography, and I'm in the office studio right now. And right after this, I'm going to run off to photograph the local high school band's car wash. And I will share with you some of the images from last night. Let's see if I can share this. Maybe not. Anyway, I go and photograph Friday Night Lights at the high school, and I frequently shared these photos with the folks. Let's see if I can transition into that. There we go. If you go to my Facebook page, my personal Facebook page, you can see some of the photos. These are from last night, and yeah, so that's what I do for fun. Interesting fact.
Oh, very cool.
And the story I'll share very briefly is that this involves your local dentist. It's just like your typical urology BPH patient. They ignored the problem for months, sometimes years before they seek care. I had a toothache for a long, long time, for months. And finally, it was no longer just cold sensitivity. It was sensitivity to pressure. So I couldn't even bite on one side of my mouth. Finally went to the dentist 3 days ago. Had it evaluated, and he said you need a root canal. So I said, okay, well, get it done. And of course, unlike medical practices, they come right in with, here's your bill, estimated $2,250. So I said, you know what, I need this taken care of. Not only did he take care of my root canal in 75 minutes, that same session, same visit, he was able to replace the crown that same day with a machine that cost him over $100,000. So why am I telling you this story? I'm telling you because it is sometimes important to keep up with the technology. He was able to mill that crown using a camera, just takes a picture of my arch, my lower arch, and then that piece of machine using computer technology was able to create a perfectly fitting crown on my tooth. We're talking, he just put it on and no adjustment needed, just cement it back on, 15 minutes, same day. It is sometimes important to keep up with technology, and today's topic, PYLARIFY, and my question to the presenters is it piflufolastat or piflufolastat? So adopt technology, keep up with the technology, keep up to date with what you do in urology and your everyday life. Back to you, Vic.
Oh, that's a great story. Yeah, I kind of wonder what hurts worse sometimes now, dentistry or the bill. I've had that I had that same feeling with it. I was amazed how they could just mill that thing out from pictures.
Yeah, so you know, it's truly amazing. I won't share another story, but I was happy to pay the bill because there's something. So even if you have tens of millions of dollars, there's one thing you cannot buy, and that is time. I value my time a lot. Yes. So I was happy to pay it. I was happy to get it taken care of and pain-free now.
Yeah. Okay, I'm going to run through a couple of these questions here or some answers, I'm sorry, from the audiences that came in. Diane says, good morning from Seattle. Susie says, good morning from Centralia, Washington. Brandy's answering about the x-ray question I asked, the imaging studies. They don't usually show them. Susie says, we show patients their images as soon as possible. Good. Hey, Ron, welcome to the show. Often show the images. Yeah, I think that's kind of a good idea. Good morning, Elizabeth. And Nancy, where is Gilbert? Near Phoenix. Yep, it's near Phoenix. And if you're going to the SUNA meeting this coming up in October, we're going to all try to get together out there. You can get together with UroNurse. So in Gilbert. All right, let's go ahead and bring in our guest speaker. Marco, go ahead and tell us a little bit about yourself, and then if you have a favorite fact or story, go ahead and give us that.
Yeah, right on. Well, thanks, Vic, and everybody for bringing me on. My name is Marco Carlos. I'm here at Urology Austin, here in Austin, Texas. So the great city. Welcome to visit. It is hot, very, very hot. So just letting you know, but come on over. We can't wait for the cool weather to relieve us from the heat. Interesting fact, I've been here for the company for 18 years. I've been in urology for 18 years. An interesting fact is when I first started, I couldn't participate in our benefits And it was a funny thing because, the guy from the 401k is there and the other things. And he's like, all right, well, let's go through the requirements, have to be full-time employees, have to, authorized to work in the US, yada, yada. And then he gets to the, has to be 21 or over. And then the whole room laughs. And, he's like, well, what's going on? He's like, I don't think it's going to be a problem, right? And everybody laughs. And, I got the kid, I was 18 at the time. I was like, hey, I can't be here. And so, he didn't know what to do. So he just goes over, he just grabs my packet and he's like, well, you don't need this, but you can listen. So I just sat there and listened. But they were really nice. They adjusted it to 18. There you go. But that was a pretty interesting fact. I guess I've been here for a very long time.
There we go. It's all yours, Marco. Take it away.
Okay, great. All right. So we have a good number of slides, but we'll get through them. There's some good ones that I like to focus on as we, kind of go through them. But started off with the first one. Let me see if I can move my slides here. It is a promotional activity, right? No CME. We are speaking on behalf of Lantheus and their companies, Progenics. And the questions that we'll take, we'll have to stick to what they allow us to say during the presentation. We have some objectives here. We want to talk about the use of PSMA imaging, PYLARIFY specific. We're going to review some NCCN guidelines and discuss some of the characteristics. We might have some nuclear med folks here that love this stuff. Most of us are not in nuclear med or in that world, but it is good to know kind of the way it works. And then some, highlighting some clinical efficacy and safety from the studies. What is it? Well, PYLARIFY is I'll just read it off the screen here. It's a radioactive diagnostic agent. We use it with PET, and it binds with the PSMA and allows us to see, positive metastatic disease or lesions in men with prostate cancer. The two indications here that are very, very important for us to, that we've always wanted was, with suspected metastasis who are candidates for initial therapy. And then obviously anytime somebody is recurring or has, increase in PSA after treatment, this scan is available for them. And we have had advanced imaging before in that space where somebody was failing post-therapy and we had the ability to use it. But this is the first time in a long that we can have an advanced imaging or targeted imaging at the beginning when people are planning for definitive therapy. And as we go through the slides, we'll discuss, we'll learn how that really plays a big role in the patient. So we'll move over to safety information, no contraindications. There are some warnings and precautions in regards to risk of image misrepresentation. There is a slide that talks a little bit about the biodistribution that we'll review. But the novelty of it also leads itself to, having to sometimes reevaluate an image. And of course, that is, done by the radiologist. And sometimes they have to, take another look to try to distinguish friend from foe. Some hypersensitivity reactions, you don't know what you don't know. And a lot of us don't know if we're allergic to something until we take it. Obviously, this is an imaging exam. So there are radiation risks, just like, CTs and MRIs and so forth that are there. Adverse reactions, most frequently reported, were headaches, loss of taste, fatigue, but overall pretty low and pretty well tolerated. There has been some discussions in the past with ADT or androgen deprivation therapy, but the takeaway here is that has not been established. Our experience at our practice and my knowledge of just working with patient navigation groups and advanced prostate cancer groups across the country, it really hasn't held anybody back from not ordering this exam while somebody's on androgen deprivation and oral oncolytics or other therapy. So we'll review a little bit of the demographics of prostate cancer here in the US, which is pretty interesting. So these numbers are from 2022. I'm sure Lantheus will update it soon and we'll have 2023 numbers. But if you look at here at the primary the diagnosis of cancer in men, 27% of the time, that's about 268,000 cases. And it's the second leading cause of death in cancer in men, as you can see there on the right-hand side. I like this slide a lot. It just highlights the patient journey and it explains how prostate cancer has evolved now and how complex it's gone. In urology, I remember just back in the day, we would treat people with for prostate cancer, surgery, radiation, and then we didn't really see them after they were failed their therapy. We thought about prostate cancer just localized or metastatic. And now we have different buckets. They're castrate sensitive, castrate resistant. And you see that journey there where the urologist and the radiation oncologist and the medical oncologist intersect. And they always have worked together. You just see more and more patients remaining with the urologist for a bigger part of their journey than ever before. But these exams allow us to be able to really highlight those patients and get them where they need to go. This is a SEER data on 5-year relative survival, and this is why imaging is so important for us, for everyone that works here in the healthcare field for urology. Localized disease and regional disease, we know it's a 5-year, 100%, but then when we have distant metastasis, that really drops down to that 30% mark. So a patient really does lose a lot, when they have the distant metastasis. And so finding it, treating it early, again, right patient, right treatment at the right time, and these advanced imaging can allow us to really help with that. So we're going to talk a little bit more about just PET. I think for the majority of my time in urology, and Vic, you might correlate this as well, is PET wasn't a big part of our world. Maybe some in kidney and bladder in more in the advanced stages, but just in prostate cancer really wasn't much there. We had a next generation imaging with laciclovine, and we started getting into the PET world, and now we're really there with PYLARIFY and some of these PSMA scans. So something for us to learn. We're all kind of learning. We've all learned how to order them, deal with the insurance aspect of it, but we understand the value that PET brings in regards to the visibility of seeing the tumor, of the met, and just having just better pictures. And we'll talk a little bit more about how it delivers better pictures. And Dr. Lin, you were mentioning how you love taking pictures, and obviously we all understand that a good picture, we can see a lot more. And there's differences between MRI, CT, and bone scan and PET. And the way I try to describe it is, with conventional imaging, we had good. Then we had next generation imaging with laciclovine that was, better. But now we have best. And this chart just kind of highlights how, what we can pick up in different modalities, but what we can pick up in PET, and kind of sort of really simplify, what the patient has to go through and what the physician has to order to be able to find these things. So definitely an improvement of what we had. PSMA is an interesting concept. I remember maybe 2020 to late 2019, 2020, Neil Shore and some of the other doctors at Urolive and talking about these presentations that PSMA was coming, and they would show slide decks of some of the studies, and they would talk about how it was going to change what we did in prostate cancer. And it is really neat to be able to see that now live. Not only did it come out and the impact that it's had, and we'll talk a little bit more about that, but PSMA stands for prostate-specific membrane antigen. I remember when we first read those concepts, we were like, man, what is it? How does this work? I like to describe it as a doorway. It's a target tracer, allows us to really find, really help the patients, the physician and the support staff, navigators, nurses, MAs, help the doctor, help that patient out. And really the way it works, and the really cool, neat thing about PSMA is really acting like the doorway. So in normal prostate tissue, it is intracellular and inside of the cell. In prostate cancer, it overly expresses itself and it's extracellular. And so now the doors, open, available to be opened by for use, and really just connecting that PSMA down to the cell, allowing it to really open, bring in that radio tracer. And now with the advent of radioligand therapy or theranostics, bringing medicine to treat the prostate cancer right into the cell. So really, really incredible. Just to understand that they figured out that they had this pathway and they're exploiting it for the betterment of the patient. F18, right, is something that they selected to use. How does it deliver great pictures? This in the next slide really just talk about how it has a high positron yield, low positron energy, and gives you great images. They're not the only people, Lantheus, to select this, radio tracer for their study. There's other people that use it, and this is why. It just gives you good pictures. Pictures, obviously is a benefit for everybody. If you're an NCCN nerd like me, you understand that there is a much updated version on here. But if you read the what's on the screen here, and then you go back and you read the most current version, the sentiment is still the same. Now, the difference is that when this was written, we really only had, this product as well as the gallium-68 product. And, now there's more. But the takeaway remains the same. The first one is how you can use any PSMA scan to really look for patients that are eligible for other radioligands like lutetium or Pluvicto, if you recognize the brand name for that exam. And so even though in the beginning, we thought we were going to have to rescan patients on gallium if they had used F18 or some other tracer to be able to make them eligible or to see, the panel really now just agrees that a PSMA positive patient on any imaging modality can really be considered to use some kind of lutetium or those kind of tests that are going to come out pretty soon across the board. So we're all pretty excited. The biggest takeaway also with the NCCN guidelines that they still feel that it is not necessary as a prerequisite to have conventional imaging. Sometimes the conventional imaging is the appropriate thing to do. And, sometimes there's a cost factor there that we have to consider. Availability is another thing, depending on where you are, if you're more rural as opposed to, having access inside of a bigger city. But the idea here is that if you have access to this, and the insurance is trying to argue that you're going to need some kind of an equivocal test or negative test before you can have this, you can't argue that back against the insurance in a peer-to-peer review. This slide gets a little merged here using here on the website, but really the Society for Nuclear Medicine and Molecular Imaging really just highlights multiple scenarios for the use, and they support what the NCCN guideline and the FDA indication is, which is basically here in the beginning, during definitive treatment or the consideration of definitive treatment, all the way through for biochemical recurrence and even in metastatic disease. So we have two big organizations that a lot of physicians, trust and follow that, are really promoting the use of this when it's appropriate for our patients. So this is a little bit of an introduction to PYLARIFY. Here is the biodistribution. We talked about that. It kind of explains why in the beginning of the slide deck, when we talked about, warnings and precautions, there was some risk for interpretation, and that's because, the radiologists need to understand, friend from foe. Sometimes it can be a little bit difficult, especially the novelty of the whole thing. But our experience here locally is, as now that we've done probably hundreds of this over the last since it became available at the beginning of the year or last year, it's gotten a lot better. We have less and less issues with trying to figure out exactly what's going on. If you're interested, this is the way we kind of get our tracer, right, from creation to transport down into where it delivers to the patient. So we'll jump into the studies a little bit, which is pretty cool. We have the patient journey again. Instead, this is more of a horizontal line than the roller coaster that we saw earlier. But you can see here from clinically localized disease all the way to what our last bucket is considered, MCRPC or metastatic castration-resistant prostate cancer. And the three studies that are there with the two birds, Lantheus likes birds. So we have Condor and Osprey. You see, Osprey in cohort A, which really gave us the ability to use it right there in the localized during deciding the physician to on definitive therapy. Condor under biochemical recurrence, and then Osprey B, cohort B, in metastatic. So let's jump into Osprey first. We have the two cohorts we just talked about, A, B. the idea here that they would, scan these people and then use histopathology as a standard of truth to prove that what the image that they saw was true, which was correct. And so we see here across the board, it gets highlighted here in the sensitivity, but across the board with specificity, positive predictive value and negative predictive value, performed really well compared to conventional imaging, and it was on par with the sensitivity here in regards with, again, being backed up in the pelvic nose with histopathology. In a post hoc analysis, it achieves criteria across all lymph nodes, as you can see there. Again, they're being backed up by the histopathology and in pelvic lymph nodes for both, whether you have the disease or you don't have disease, based there on sensitivity or specificity. The cohort B in metastatic disease performs very well overall, bony mets, lymph node mets, and visceral disease. Doing a great job for both, sensitivity, finding that disease, and having the ability to treat it or do something earlier. I just like to repeat myself: right patient at the right time, the right treatment at the right time. This slide shows, a sub-analysis when compared to conventional imaging on whether or not you got upgraded or downgraded. And so you see there from going from M0 or no disease to being M1, down below having M1 being a little bit more specific to your right on whether, on the site, but also moving you over to the non-metastatic. So, it showed that maybe there was something there, in the repeat with PYLARIFY, it was a lot more specific, a lot more targeted. And so we were able to rule it out and then continue with, kind of creating a treatment plan for the patient. So there's a change in therapy here. And then we'll see that too when we move on to Condor. Here's a case study that just shows us and highlights the differences here. We have a patient's baseline description on the left. If you notice, pre-PYLARIFY, plan was to undergo surgery with bilateral or probably pelvic lymph node dissection. There's a bone scan 4 weeks before PYLARIFY. Everything looks great. There is a post-op, post-PYLARIFY, scan. You see that on the right-hand side, and then you can see how it's upstaged to having nodal disease as well as bony mets in the image. And so the change here is we divert away from doing surgery, and the physician now chooses to go with androgen deprivation therapy and abiraterone acetate with prednisone. So now we move over to kind of that dual. So Condor had a very interesting concept when they was presented to the FDA to use something called CLR, or correct localization rate. The best way to describe this is they went to the FDA and said, hey, we're going to scan these people, and then we want to measure what we find up against standards of truth, and we want a one-for-one match. That's what we're looking for. If we saw something here, we want to find a different way to confirm that, and then give us, a CLR. And it's a little bit cut off there because of the way this projects, but the FDA agreed to an approvable threshold of 20%. So you guys can do it, but that's your threshold is 20%. Here's a Condor design. You can see, how people were lined up to get PYLARIFY, and then if there's a lesion detected, there's your standard of truth using, histopathology, using conventional imaging or other imaging like MRI, CT to correlate the finding, as well as PSA response to, confirm that this was related to prostate cancer after treatment. It's interesting, the percent of patients who had PSMA avid lesions on radiology assessment, 69.3%, which is good. Also, when thinking about ahead in whether there'll be candidates at some point for diagnostic or radioligand, the TCM type treatments with PSMA. So here's a Condor case study, which is interesting. I think we may have skipped a slide here. I'll go back. There's a little slide that's missing here just because of the way it works, but on the CLR, it really showed the PYLARIFY went way beyond that threshold, in all PSAs, going from low to high. And it also showed that you were able to detect metastatic disease and a lower PSA. So you can see that kind of in the background a little bit. But let's just kind of sort of translate that into a case study with Condor. 54-year-old male here. You can see the description. There's his surgical pathology. He has a negative flucyclovine PET CT. Oxymon is the brand name. So if you remember it by that name, again, this was what we had before PSMA, and we used it and we loved it because obviously it was a lot better than conventional imaging. Good, better, best, right? So the plan with that negative scan PET with flucyclovine was for radiation therapy. So we get, here's our standard of truth again, that kind of correlates to the beginning of the study, histopathology, conventional or PSA response. Again, explaining how they got that CLR or correct localization rate. And here is, the results of basically a head-to-head using that advanced imaging, right? So now we're not comparing conventional imaging that we've had before, CT, MRI, bone scan. Now we're going kind of sort of PET to PET. It's the tracer that's making the difference here. And so you look at, PYLARIFY versus Oxyum, so that people understand and remember that. You see several areas of activity there in the whole body compared, you don't see anything on the other, but it does pick it up with the PSMA PET CT. These are just some pictures, some transaxional pictures. You can see the little perirectal node there, present with PYLARIFY, but not present with flucyclovine on the left. This is just another section, another of the nodes that we found, as you can see here, and going to get treated. The change in management was to proceed with. So this plays a big role in really looking for the right treatment for that patient to make the best impact possible. And having those better images is allowing our physicians, our radiation oncologist, our urologist, or our oncologist to really make things that really impact the patient long term. Again, we just have better imaging, better availability. There was a big thing on a secondary endpoint that they saw on Condor was a change in patient management. And if you look there, 64% of patients had a change in what they were going to do based on the imaging, which is great. They were either going to do, we'll see that on the next slide. That change could have been an escalation or de-escalation. But the call out here is the basis for change in management, and 79% of those were positive findings, while 21% of those were negative. So again, we're going to have to change. We're going to have to go higher or lower in how aggressive the physician is based on what they're seeing, which is, we have to accept that would create better outcomes for the patients. And here is our, treatment plan shifts, and you can see escalation, de-escalation, moving over from local to systemic, right? So I remember when I first started navigating advanced prostate cancer, I thought that every patient needed everything in the kitchen sink. I mean, everything under the sun. But we've learned now that the way people feel, there's a shared decision making. There are side effects to consider, quality of life to consider, and having imaging that allows the physician and us to help the patient make those decisions that are better for him. So, just treating advanced prostate cancer has really helped us kind of sort of learn a lot on how to really have all the considerations for the patient as we move forward in a bigger way. So we're at the end here. We're going to talk about safety, and it's really towards the end of the talk here. Again, pretty well tolerated. Here are your most common adverse reactions if a patient asked. Obviously here again, headache, loss of taste, fatigue, one of the most common. We talked about misinterpretation. We talked about the biodistribution, right, of PYLARIFY. Lantheus offers an AI that can assist the radiologist and the physicians to try to figure out friend from foe. So if you are a radiologist or work in a radiology center and you're interested in something like this, just talk to your local rep, and they can help you figure out what that software, how to get that software in there, and help you, kind of get over the novelty of this exam if it's still very, very, very new to you. In summary, we learned a couple different things. The takeaway here is we have better imaging, and not only do we can endorse it anecdotally, in our individual clinics, but we can also have the endorsement of our, NCCN guidelines, the SNMMI that tells us, hey, we should use it in the appropriate scenarios. The clinical studies allow us to make arguments when the insurance is kind of sort of giving us a hard time. I'm sure everybody on the broadcast has stories of payers flying right through and other payers giving us a hard time and not getting the patient what they need or having us to jump through hoops. The takeaway there is that you do have data that you can rely on, both using the clinical studies and the guidelines to argue. And, if there's any the other physicians or providers on the call, we all know that the chances of the peer-to-peer, somebody saying no, are slim. Most of the time they say yes, but, we always appreciate when the provider is, willing to jump through that hoop for the patient to get that official yes, on that peer-to-peer.
Hey, that was really great. Appreciate your presentation. At this point, if you have any questions for Marco, please put them into the comments section. I'll be bringing those up. Again, for those of you that won't be able to see the slides because they're going to be removed on demand. A couple of points. So I'd like to ask, where do you see this being used in your practice? So patients diagnosed with prostate cancer, when does the PYLARIFY PET scan come into the treatment?
So we use it based on the FDA indications right there in, we've used it a lot when we're looking for that suspected metastasis in, in definitive therapy. Our radiation oncologists here locally in our practice have really gotten used to it when they're doing their planning for radiation. And it has made a difference in some instances where, a PSMA was ordered and the patient came back and actually had, oligometastatic disease. And so that changed the plan completely, or it changed the amount of ADT, also along with the pathology. We use it again in all biochemical recurrence when we can, and we use it a lot in our advanced prostate cancer. And then we do understand that there's sometimes limits to the number of PSMA that sometimes people can get based on insurance. So we don't use it as, I wouldn't say at first we wanted to use it very routinely on everybody, like everybody and their daddy should have PSMA. But now we've learned a little bit more about, and we try to use it. I see the physicians being a little bit more judicious on when, we try to keep it as the FDA to have it available for them.
Great. We do have a comment that came in from Susie Swain. Is PYLARIFY covered by most insurances? And Carrie, if you want to comment on that, you're welcome to.
Yeah, I'm happy to take that one, Marco, if you want me to. I think when you say, is it covered, that's a little tricky because, I'm new, fairly, I've been in this imaging space now with Lantheus and PYLARIFY for a couple of years. And I've learned that a lot of imaging does take, these, you're getting your prior authorizations. Oftentimes, like Marco said, you might get denials. And so then the appeal process is there in peer-to-peer, and this is pretty standard, although very frustrating, I've learned. I think when looking at it two ways, when you're ordering a PYLARIFY scan for a patient that could be having a recurrence, I hear it's a little bit easier in that setting because like Marco said, we had Axeman, that PET scan that was in this space only for patients who might be having a recurrence and in the BCR space. So that I think the payers got used to. So ordering for that type of patient could be a little bit easier. Now, when you look at ordering PYLARIFY for a newly diagnosed patient, that's again, like Marco said, fitting the NCCN recommendations, fitting the indication. It's for patients that are high and very high risk, based on their biopsy. It still can be a challenge. Most of the payers, I guess, haven't really embraced using PET CT for these newly diagnosed prostate cancer patients. So they're often going to deny this request. So it involves the appeal. In some cases, you're good there. In some cases, you are going to the peer-to-peer. But like Marco said, I see that it's gotten a lot quicker, that whole process, and much more successful. And I think with anything, the more you order and the more you get used to it, the easier it gets. I've learned from my customers that radiation oncology seems to have really good success at getting these requests through for the newly diagnosed patient. So it's a little bit, depends on the stage that you're using it for or the indication, but it's gotten a lot better over time. Trust me, in the very beginning, I worked with, whether it was a nurse, an MA, or maybe a nurse practitioner that was doing these prior authorizations, and they were pulling their hair out in frustration because it was so new. This is all brand new. And like Marco said, using this PET CT scan for a newly diagnosed patient, totally unheard of until now. So yeah, we've come a long way.
Susie, just to give you some context, I have no financial relationship with PYLARIFY or Lantheus. I'm a user. I've been a user for quite a while. Yes, it's a relatively newish type of a test, and the guidelines by the NCCN has been evolving, and now it covers the use of PYLARIFY PET CT for certain types of patients, such as unfavorable intermediate risk prostate cancer, high risk prostate cancer, or if the patient had prostate cancer that was treated and now you suspect that, hey, is there a cancer coming back? Is the PSA going up? That's another reason to get these tests. I think of these new, and I'm sure Lantheus will not be the only company making this type of test. I think of these PSMA testing suite of tests, like what you're seeing behind me. These are PSMA is a way for these beacons to attach to prostate cancer and start lighting up like this to say, hey, I'm here, prostate cancer, I'm here. And that is picked up on the PET CT. This type of imaging makes it a lot easier, a lot more sensitive to pick up those cancers, those occult cancers that are not picked up by conventional imaging, bone scan, whole body bone scan, or CT scan of the pelvis, for instance. So much better. The hurdle with these types of tests is relatively new, right? So you have to fight with the payers, the insurance companies. Thankfully, it's gotten a lot easier. The early adopters, of course, have to jump through the hoops and fight with the insurance companies. But as we all use it more and more, the insurance companies will realize that this is now the standard of care. If I have prostate cancer, if I have unfavorable risk prostate cancer, I am going to want a PYLARIFY. I'm going to want a PSMA study to make sure that truly my cancer is confined to the prostate and has not spread outside of the prostate, because treatment is very different. So the right test for the right patient is very, very, very important.
Yeah, thanks. We do have some more questions coming in here. Elizabeth Hernandez wants to know, how long has PYLARIFY been in use?
In Austin, well, we got it November of 22. It became available, self-pay. Carrie, and I think Medicare added it in January of 22, correct?
Yeah. And in the Chicago area, so there was a couple study sites here in Chicago. The official approval was in May of 2021. And in the Chicago area, the first commercial doses went out in July of 2021.
Great. Let's see here. Elizabeth said, great analogy, Dr. Lynn. Always.
Thank you.
Brandy says, so newly diagnosed and not necessarily high risk, what is the best route for approval?
I have some thoughts on that. Did you want to jump in, Dr. Lynn?
You're going to have to fight with the insurance company, and you may have to go through second level appeal, peer-to-peer type of interaction to get it covered.
Dr. Lynn said unfavorable intermediate is also within the NCCN recommendations to utilize this test. So right below high risk is going to be your unfavorable intermediate. So maybe they can fit that criteria instead.
Providing NCCN guidelines.
Yes, that would help.
That's available. Yeah, providing guidelines will definitely help. Yeah, that's available online.
Again,
you're welcome, Susie.
Thank you to Susie from Susie. Any other questions, folks? Go ahead and put those into the discussion. Again, I find this fascinating. I think this PMSA, besides as a diagnostic tool, maybe something that's going to be showing up as future targeting. Not only is it showing up where the metastasis is, but how do you create something that can go in there and kill that?
This is so exciting. Diagnostics in this type of a field is just emerging. Imagine being able to find something that selectively sticks to the cancer and then carry the treatment to that cancer. That's where we're headed right now.
Yeah. And I think that's always been the goal in medicine, is targeted. In the old days, radiation therapy, and I've been around in for the old days, they just like blasted everywhere. That's why you had all these complications, the, mucus from the rectum, because they were over radiating the rectum and all this. It was just this, like they say, kind of sometimes throwing a hand grenade to kill mosquitoes. It'll kill them, but it kills everything else too. So I think this targeted approach is great. And I look forward to hearing more about as it progresses.
And we have that diagnostic already available, right? With lutetium and 177, brand name's Pluvicto. And there's another one coming out soon. So just like Dr. Lin said, just to have them, Dr. Lin, do you remember those years ago when they were doing those, Uro live sessions, I think, or Onco live sessions with the PSMA, and they were it was almost just like a plot graph of these tracers.
It's all fuzzy.
All fuzzy. And now we kind of understand the way it works now. And to have not only the imaging, but also the treatment portion of it, it's really super exciting.
The ability to detect tiny little metastatic tumors is really just amazing.
Right. We've seen an increase in our oligomets. I don't know, Dr. Lin, if you've seen that too since PYLARIFY in our radiation center. Just now that it's there, we had to really wrap our brain around it and say we need to do a better job of treating this disease, because it was probably always there, it just wasn't visible.
Correct.
So that's been something that's been probably the single biggest change in the last 12 months, or since we really got PYLARIFY or PSMA in general to be used in the practice, has been an increase of oligomets.
So Marco, do you work in an imaging center, or are you part of a urology practice that has this type of technology?
No, I work at a private urology practice, and we have the imaging available through our local imaging company.
Oh, okay.
Yeah.
Same with
so
me.
We use it, but we have our radiation center, and so we just tend to work really close with them.
Got it.
Great. If you have any other questions, folks, now's your chance to put those through. Otherwise, I think we're getting towards the end of the show. Marco, I really appreciate all your insight into this. Again, I think that this is kind of a fascinating new area. That's why when I met with Carrie, I said, hey, this is something we got to get on UroNurse. I want to find out. I always like to find out about what's new and exciting. And this is definitely qualifies for that. I think that it's good to stay on the kind of the top of your game, even if you're getting out of the game eventually. It's always good to kind of stay on the top of your game. It's important to educate yourself into what these options are. And not only for, like, as we said, for treatments, but who don't you treat? If somebody's got metastatic disease, do you really want to go trying to put them through something that's not going to cure them? So I think it's always important to, I think the more options you have for patients, the more information that you can share, the better. So,
I've been using PYLARIFY for quite longer than since November, because I remember the way I learned about PYLARIFY, and I was fascinated by the spelling, or how do you pronounce piflufolastat? Is it piflufolastat or is it piflufolastat? As an immigrant, I'm just fixated on correct grammar and spelling pronunciation, so I struggle with the English language. How I learned about PYLARIFY was I was attending a meeting about prostate cancer, and Bella Dennis, he's a former attending of mine, was there, and he said, oh, you got to check this out. And that's how I learned about PYLARIFY. I interviewed a couple of your Lanthea staff, Beth Lakey. You can see, if you search John Lynn PYLARIFY on YouTube, you'll find the two interviews that I did, and with Philip Koo, Dr. Koo as well, talking about it. the only reason I found out about it is by attending one of these meetings. And I like to encourage everyone to consider attending the annual SUNA meeting that is going to be held here in the Phoenix area. So look up SUNA, I think it's suna.org, and look up where the annual meeting is going to be held. A lot of vendors will be there, and you'll get to learn the latest and greatest.
Absolutely. We do have a few more comments coming in here. Let's see. Oh, we got thank yous. Thank you, Marco.
Thank you, Elizabeth.
And Brandy says, thank you all. Very informative. Yeah, great. I'm glad everybody appreciated it. I thought it was a great show, too. Anyway, let's wrap up the show here, folks. And I'm going to give a plug for next week's show. Next week, we're going to have the Ellatone folks coming in to talk about an external pelvic floor therapy. Actually, the CEO was a patient. That's why she's going to be talking about it. So it should be interesting to learn about these new treatment options out there, especially things I think people can do in the home. Hope everybody has a great weekend and enjoy this. We got nice sunny weather here. Hope it's nice and sunny by you. And otherwise, we'll see everybody next week. Have a great day, everyone. Goodbye.
Right.
Thank you so much. Bye, everybody.
Bye.
Goodbye.